I would like to apologize and also good evening. As Dr. Kinoshi have introduced me, I'm Dr. Vuyi Titus. I'm based in Mafeking Provincial Hospital in a level 2 hospital. I'm also working in Victoria Private Hospital, as he has alluded. Then I would like to apologize for that glitch. And also I would like to correct that I am not having registrars from Medunsa, but I am having community doctors and junior doctors who go through my unit, who some of them end up being specialists after going through me as part of the motivation and the mentoring. I'll also like to declare that I don't have any financial benefit from Clinix. When Clinix asked me to do a presentation, initially I thought what could be the best topic. Then after talking with the local general practitioner, then I realized that we do have a problem as far as the approach of acute bronchiolitis in children. Moreover, when you look at the burden of bronchiolitis itself, and as far as having a lot of kids who are being admitted in the hospital, some of them not necessarily need to be admitted. Some of the patients, which especially with morbidity, because I also work in level 2 hospital, where I do have an experience of getting one of the patients who happen to develop a brain injury because of us not necessarily having approached the bronchiolitis as it's supposed to be approached. Therefore, I felt that this would be a necessary topic to discuss. And also given the burden of antimicrobial resistance, and because of the overuse of antibiotics, especially that mostly every child who has got a respiratory tract infection, we tend at the primary level assume that to be the bacterial cause. Therefore, I thought it would be necessary for us to discuss the acute bronchiolitis in children. Therefore, colleagues, I decided to just come. Of course, I must declare also, I'm not a pulmonologist, I'm not an infectious specialist, but I'm a primary pediatrician who part of the responsibilities to make sure that we reduce the mortality and morbidity, and also to educate the parents as far as management, as also as far as of prevention of some of these diseases, especially that acute bronchiolitis is one of the preventable problems, especially if we adhere to some of the things which I'm going to allude in. Therefore, colleagues, I'll start with my presentation. I'm presenting acute bronchiolitis. My objectives in this presentation, I'm just going to a little bit discuss the extent of this as far as epidemiology, and also I'm going to look at the causality and also the clinical manifestation so that we're able to diagnose it correctly. We're able to differentiate it from pneumonia. And I'm also going to quickly go through some of the patients who might be presenting like acute bronchiolitis, which are not necessarily bronchiolitis. Then I'm also going to go through about the treatment modalities as far as acute bronchiolitis is concerned. Lastly, I'll touch on how can we prevent the acute bronchiolitis. My first slide generally is just the definition. Bronchiolitis itself is an inflammation or a disease of the small bronchioles with increased mucus production and occasional bronchospasm, sometimes leading to airway obstruction. It is an acute viral lower respiratory tract infection and is commonly seen in children, in infants and young children, especially less than 1 or less than 2. Of course, every can get RSV infection. Only is the symptomatology or the severity you tend to see in those ones less than 1 year to 2 years. And RSV is the primary cause of bronchiolitis. Therefore, it doesn't mean that other viruses cannot cause, but commonly about 40 to 60% of bronchiolitis is caused by RSV. And bronchiolitis is a potential life threat. Mainly, when I say potential life threat, that it, if you don't recognize early, you don't act early, you wait until the patient is in respiratory failure, then you can end up getting patient dying from bronchiolitis. As I said, in my level 2 hospital, we once had a patient who subsequently developed a cerebral palsy post bronchiolitis because of the respiratory failure. We didn't see the impending respiratory failure. Just to quickly, I'm just trying for us to enjoy the management and also to enjoy the pathophysiology. Then when you look at the bronchiolitis, I've said is inflammation. When you look at these slides and compare to the normal, you can see that there is an inflammatory reaction there. As a result of this inflammatory reaction, you are going to get collapsed alveolus, and also you might also get the air trap, those one who will subsequently lead to respiratory failure. I'm not going to, for due of time, I'm going to jump these slides. We're more explaining more as far as the pathophysiology. Then I'll go to etiology. What is the causal? What causes bronchiolitis per se? As I mentioned, the commonest cause of bronchiolitis is respiratory syncytial virus. Respiratory syncytial virus is basically a single RNA virus in a genus of pneumovirus and in a family of metapneumoviruses, and it uses autopneumoviruses and is in the same class with human metapneumoviruses. Then also the para-influenzas and others, including rhinovirus, adenovirus, which adenovirus can give you the severe up to, it can lead to bronchiolitis obliterans. Then also there is evident that some of the bacteria, especially mycoplasma pneumonia, can cause bronchiolitis. But of course, the commonest cause is RSV. But we need to bear in mind, colleagues, that as much as I'm mentioning each and every one, some of these viruses can co-infect in the case of a bronchiolitis. Therefore, you can get two viruses instead of virus in a patient when you do the test in a patient with bronchiolitis. Then the transmission is very important to understand the transmission so that we are able to prevent, we are able to understand the prevention modalities. This is an extremely contagious and is spread by contact with infected respiratory secretion. Therefore, if you've got a child who is infected and you mix with this child with other children, because this child is breathing, this child can also can infect. Also an adult or some of the adults can also have RSV. It can infect because is what you call it, is spread through respiratory secretion. Another important thing is the fact that the RSV can stay about 6 hours in a heart surfaces. And also it's important that up to 2 meters, you can still infect a patient. Therefore, it's very important when we think about the prevention. Then the head carriage is another important thing. If you have got a physician who's managing a patient who has got bronchiolitis and the patient doesn't have a bronchiolitis, you are more likely to take with your hands when you are touching this patient, or sometimes with the stethoscope. Therefore, it's very important to understand that the hand carriage is also one of the transmission modalities in acute bronchiolitis. Then there are some patients, especially in the children population, who are more susceptible to bronchiolitis than others, especially within a group of premature infants, children with the chronic lung disease of the prematurity, hemodynamically significant congenital heart disease, especially those ones with increase in pulmonary blood flow, the neuromuscular weakness, especially spinal muscular atrophy and others, immunodeficiencies. Even in the case of HIV, you can still get, you are susceptible to acute bronchiolitis, the Down syndrome patient, of course, and the cystic fibrosis, and some of the congenital structural airway abnormalities, and in some of the patients who might have to put tracheostomy for whatever reasons. All those patients are susceptible at risk to have acute bronchiolitis. Therefore, in our management of acute bronchiolitis, we should bear in mind that there are some of the patient children who are at risk. Therefore, those children who are at risk might be the one who might have to, if it means we might end up having to be careful in monitoring, you might end up having to start antibiotics sometimes in those patients. Then the epidemiology. Bronchiolitis is the most common serious respiratory infection of infants. Of course, also other common serious respiratory infection of infants is pneumonia, but it's very difficult to differentiate between bronchiolitis and pneumonia on the clinical presentation. Therefore, it's important for, as I look on the clinical update or in the SAMJ by Ziad and the group, looking at a differentiation between bronchiolitis and pneumonia, especially after COVID. We need to bear in mind that after COVID, sometimes also pneumonia and bronchiolitis, the causality can be the same, which is an RSV. Then the other important thing is that bronchiolitis is a leading cause of hospitalization of the infant. But when you look at the review and the literature, you find that some of the patients which we admit are not necessary to be admitted, but of course, bronchiolitis is still a commonest. And it occurs exclusively during the first 2 years. It doesn't mean that patients who are more than 2 years cannot have bronchiolitis, but mostly those less than 2 years tend to have a severe infection. I'm basically saying rather that RSV, they can still have RSV, but bronchiolitis is commonly in the less than 2 years. And the peak is between 2 to 6 months. And in a USA context, their peak time is between December to March. But with us in South Africa, it's commonly from February to March. Of course, it depends where in South Africa. And bear in mind, colleagues, that RSV does occur all year round. Though I'm saying the peak is between February to March. Then the clinical manifestation. Generally, bronchiolitis is a classical present as a progressive respiratory. What I mean by that, initially, they will present with just upper respiratory tract features like rhinorrhea, cough. Then it will progress over 3 to 7 days to present now with noisy, raspy breathing, audible wheezing, low-grade fever. Initially, they may reflect the work of breathing, decreased oral intake. And young infants with RSV may also have apnea as a first sign of infection. Of course, when you look at the clinical signs, there are some grading where you are grading based on the clinical features, and that you grade you'll grade the bronchiolitis according to mild, moderate, and severe and severe. Then I am going to show you a good slide about that. Then the clinical signs, mostly the clinical signs are more likely the clinical signs of most respiratory, including pneumonia. But the most important thing with bronchiolitis, you shouldn't miss the features of hyperinflation, especially hyperexpansion of the lungs, and the percussion. On percussion, you have a hyper resonance. Also, this patient can have what we call positive Hoover signs, which is as a result of inspiratory retraction of the lower intercostal spaces as a result of obstructive aortitis. What happened with this, basically we're saying, because we've got a flattened diaphragm, this flattened diaphragm will pull the lower intercostal muscle laterally. Then you see, but again, the Hoover sign is not necessarily pathognomic for acute bronchiolitis. Another important presentation, they tend to have diffuse wheezing and crackles throughout the breathing cycle. You can see throughout breathing cycle. Basically, when you compare with pneumonia, the wheezing and crackle are not throughout the breathing cycle. But also, if you get a patient with a poorly edible breath sound, you need to worry there. You didn't say, no, it's less likely to be bronchiolitis, because it's basically talking about a severity that there is an obstruction of the bronchus. Therefore, you need to be careful as far as the management of this patient is concerned. Some of these patients can also present with severe disease granting, and granting and cyanosis may be present. Just this following slides are basically for, sorry, these slides are just more of a diagnostic illustration of the features generally. I'm not going to stay much. I'm going to close, but generally it's just to illustrate what I've been telling you, colleagues. Then also this one. Then this one is an important one where I'm talking, where I was talking about initially, they can present with a mild. When they progress to moderate to severe. Usually in the first 3 days, they're basically mild rhinorrhea. Then subsequently, they can go persistent, and the peak point is usually around 4 to 7 days. Then from there, from 12 days downwards, they start recovering. They can continue coughing for about 2 to 3 weeks. Therefore, when you get a child coming to coughing for about 2 to 3 weeks, don't think about more likely asthma. You have to take the history because it might be still bronchiolitis. Then another important thing which I didn't also mention is that sometimes we do score the severity of the according to modified Titus score, but that score basically sometimes it varies. It varies depending on the clinician. But the most important thing, you grade it. The grading, you use the two objective, that is the respiratory rate and the saturation. Then the other markers are not necessarily objective, especially the wheezing and wheezing and crackles, and also that's what I mean by objective. I say it depends on the experience of the clinicians, but the respiratory rate and the saturation you will always. But generally, that score is more important in a case where you are deciding whether you need to take this patient to ICU. At the primary level, when you see the patient when you see the patient as a GP, you are more interested in saying, are there any signs? The signs of severity mainly will be if the patient is refusing to feed and tachypneic, refusing to feed, tachypneic. These are the things which will make you say, I think I might have to refer this patient to the hospital. Here I was just try to highlight that you do have sometimes some of the patient with bronchiolitis are not necessarily sick, what we call happy wheezers. Is the other healthy child beyond age 3 is often when this guy comes, they can come with cough and wheezing. Therefore, when you see this child, you also think about bronchiolitis. Don't necessarily think about more. I'm dealing with asthma. The laboratories and emergencies. And honestly, all the guidelines, they don't necessarily encourage the laboratory or imaging in a case of a pure acute bronchiolitis. Even in the paper from the update, the clinical update by Ziad, as I've mentioned, they don't necessarily encourage any laboratory test as far as bronchiolitis is concerned, imaging, but there could be specific reasons where you would do that. Even the Italian guidelines don't really encourage that. But what sort of investigation? One important thing which you have to make sure that you do will be pulse oximeter. But of course, I understand at the GP level, some of the GP might not be having the pulse oximeter, but the most important thing will be the clinical picture. You need to be able to examine your patient thorough. Basically, you are looking at any tachypnea, wheezing, hyperinflation, any features of hyperinflation, so that, and also you take a good history as far as the fitting, all that, so that you are able to refer this patient quick. Then the pulse oximeter is very important. Also, is a decisive whether you need to admit this patient or not, especially if the saturation is less than 92. You might have to admit this patient. And the monitoring, the frequent regulars, and unless, especially if you have admitted the patient with acute bronchiolitis, it's important to review this patient because their presentation is a minute variation. That is, you can leave a patient being look like it's stable, but the condition changes. Therefore, it's important to monitor. If you are able, it would be nicer to monitor every 15 minutes. But in a case where you can't, then you can ask the sisters to review the patient, tell you if there are any changes. As far as the doing the test to look for RSV, that antigen test, PCR, again, the role of the test are not really, because one, you can get the co-infection, but in a case where you want to isolate the cohorting, you want to isolate your patient, you can do the PCR RSV, but it's expensive, or you can do the antigen. Then the other thing, in a case where you are worried of overuse of antibiotic, you are not sure what you are dealing with, you might have to do you can do the PCR to make sure. And lastly, for epidemiological purposes, that if, for example, if you have seem to be having an unusual admission of a respiratory problem, you are worried what could be, then doing the PCR for RSV. But generally, there is no rule, there is no need to do in all the patient to do the RSV in this patient. Other thing as far as blood is concerned, the FBCs, the CRPs, all that, ideally, also they are not really recommended unless you are dealing with a patient who has got an unusual presentation. For example, you're dealing with a severe acute bronchiolitis. If you are dealing with a patient with the temperatures which seem not to be cycling for 48 hours, or if you are dealing with a patient who have got, as I've mentioned up there, the risk factors, the prematurity, all that, because you want to check whether there could be a co-infection with the bacterial. Then some studies can say when we do think that this bronchiolitis, there's a bacterial agent. Sometimes it's very difficult, but in a case where you have got a CRP of more than 40, and again, that one is just is not really an absolute. Others will talk about leukocytosis, which again is not an absolute. And again, in a case where you have got a patient who's so sick who needs to go to an ICU, in that case, or you have got a patient, as I said, with the risk factors, those are the patients which you might have to think about excluding bacterial infection. Chest X-ray. Again, as far as chest X-ray is concerned, in the case of mild, moderate bronchiolitis or bronchiolitis, there is not, chest X-ray is not really necessary. Mostly it will tend to show you the features of hyperinflation. But from the junior point of view, doctors, you might think that there's a consultation because of the problem of localized atelectic acid. And again, the X-ray changes of pneumonia might not necessarily tell you that I need to start antibiotics, because common cause of pneumonia nowadays is more of a viral infection, especially with the era where we've got Haemophilus influenza virus and vaccine and pneumococcal vaccine. There has been a reduction as far as bacterial cause. Therefore, we need to be careful to use an X-ray as a marker of saying I've got pneumonia, therefore I have to start antibiotics. Also, in the Italian guidelines, they were talking about the use of a chest ultrasound. I'm not sure most tertiaries whether they do use the chest ultrasound. Chest ultrasound, where they felt is sensitive, again, is not indicated in all the patient. The differential diagnosis. Yeah. On the differential diagnosis, the most important one which you have to think about, again, basically, we have seen that sometimes with the acute bronchiolitis, we tend to abuse the treatment for asthma, the bronchodilators, assuming it's asthma. But in the case of asthma, you need to look at the age of presentation, mostly more than 2 years, though I said you can still have less than 2 presenting with asthma. Look at the presence and the absence of personal or family history of also the history, the family history of either atopy, also the past medical history of either atopy on the children, like eczema, rhinitis, conjunctivitis. Those are the things which make you think more likely to have possibility of asthma. Other differential diagnosis which are very important, it's airway foreign bodies. The foreign bodies, mostly this patient will be the patient who comes and they keep coming to you after you have initially diagnosed having bronchial, no response. Then you should pause and say, am I dealing with the airway foreign body? And also they tend to have they tend to have a unilateral decrease or decrease in entry, not going to be bilateral. A cystic fibrosis, again, fibrillary fibrosis, there will be also other associated. Gastroesophageal reflux disease, another important thing, especially I've seen some of the PREM patient, ex-PREM patient who come with a recurrent respiratory tract infection, query bronchiolitis. Subsequently, you realize that in your history taking, you miss asking about the frequent MSCs. Therefore, you might end up missing this. But therefore, gastroesophageal reflux disease is very important when you do your differential diagnosis. Cardiogenic asthma, those ones is obvious. The congenital airway obstructive lesion, again, those ones are very important to think about, especially in those ones which will come with a recurrent respiratory problem. And there's a patient of chronic lung disease, viral and bacterial pneumonia. The viral and bacterial, as I've mentioned, sometimes it's very difficult to differentiate, especially at the junior doctor level, between the pneumonia and bronchiolitis. But the most important thing we need to know to realize that it will be on the clinical examination and history taking. If your history taking is going to tell you if there are prodromal signs of upper respiratory tract infection, and also on the clinical, if there are features of hyperinflation, and also the wheezing, the minute-to-minute variation, all those things are going to tell you that more likely I'm dealing with bronchiolitis than dealing with a pneumonia. Of course, sometimes it's very difficult, even with the senior doctors, to differentiate between the pneumonia and bronchiolitis, but your clinical picture is the cornerstone in the differentiation. The treatment. Now, on the treatment, again, where we are always excited when you go to a conferences or you go to a new literature, always looking at what is new as far as management of bronchiolitis is concerned. Again, I might disappoint you, colleagues. The management is still more supportive as far as, because this patient, they come with a problem of nasal congestion. Therefore, you might have to make sure that you suction this patient, especially the infants. And also you might have to look, first make sure that the saturation is more than 32. Then we might have to give oxygen if it's less than 92. Then you might have to monitor for apnea, especially in those preterm babies or ex-prem babies. You might have to control the fever. And also the hydration is important, and feeding. And hydration and feeding is very, be mindful when you are doing hydration that sometimes the acute bronchiolitis can lead to syndrome of inappropriate. Therefore, the type of fluids you are using, you need to be careful. Then the other important thing will be the mode of feeding in the suspect. Therefore, you might have to make sure that you are using the nasogastric tube when you feed this child, especially those ones who have got a severe, moderate to severe pause. You don't want them to aspirate. When I was excited thinking that I had a new colleague of mine in 2 years back, who was a newly qualified registered pediatrician, was excited about hypertonic saline as being the magic for bronchiolitis. When I was doing my review, I realized that it looks like all the things which we think seem to be working, they are not necessarily indicated in a patient with bronchiolitis, starting with bronchodilators, corticosteroids, especially the fact that the bronchodilators have got its own side effects. When we use it, we need to be mindful. The way literature was saying you can start and stop, but now both the beta agonist, as in salbutamol, and also together with adrenaline, are no longer really advised and critical. But in some literature, in those ones which need the ventilator or intensive care, there are evidence that you can use adrenaline and corticosteroids. It can help. But as far as other, even including hypotonic saline, there hasn't been proven to be effective, both on the clinical update or by Ziad and the group, and also in the update as far as the Italian guidelines. All of them were disputing antibiotics. The antibiotics should really be avoided unless there's a strong suspicion. As I've alluded, one of the suspicions is that if you've got one with severe bronchiolitis, if you've got one with need intensive care, if the CRP is more than 40, or if they've got leukocytosis, also if they've got a risk factors, then, but when you use the antibiotic, again, which antibiotic you're going to use is going to depend on the microbial data. That is what common the bugs are you having in your area. And when you use it, please document, to make sure that you document. And when you use it, also when you get the result, the response, you should be willing to stop as quick as possible. As quick as possible, because remember, we are at that era of antimicrobial resistant superbug, and antibiotics to antimicrobial resistance is very important so that we can avoid the product of this of super resistant bug. In a nutshell, what am I saying, colleagues? I'm saying, colleagues, the management of acute bronchiolitis is still oxygen, respiratory support, you control your hydration, and the feeding. Other treatment modalities are not really recommended. Also, the use of metolacast, the use of DNAs, the use of inhaled furosemide, all those things are not, there's no evidence, are not recommended. Even the use of methylxanthine are not recommended in a patient with acute bronchiolitis. You can get patients with acute bronchiolitis who might end up going to ICU, to intensive care. But from our, as I said, there's one patient on our side, one who went to ICU. Unfortunately, I think we delayed to take to ICU. The patient ended up developing brain injury. But the majority of the patient with bronchiolitis, they tend to present with mild to moderate. You rarely get the severe unless your monitoring also in the ward was not enough, and also other treatment, including, as I said, some of this treatment have got its own including the fluids themselves. You need to monitor how much you are giving this patient to avoid causing unnecessary fluid overload. The indicate when would you send to hospital? Of course, I must be honest, sometimes referring to a hospital, especially at the private level, is based on the anxiety from the parents and also yourself as a doctor. You want to practice a defense medicine where you say, I don't want to be sued, I don't want to be wrong. And also these are your clients, you are private, you would like them to come back again. But the most important thing indication will be if on your clinical examination, the patient has got moderate to marked respiratory distress, and if clinical the child is cynosed, if there's apnea, if there's inability to tolerate oral feeding, there's sometimes, especially where we are staying, this is a rural area, sometimes you are not sure about the home situation. And lastly, the high risk, as I've mentioned, the high risk being the prematurity, the Down syndrome, the cardiac, all that. These are the patients which you might have to send to the hospital. Complication and prognosis. Most hospital children show marked improvement in 2 to 5 days. Therefore, there is no reason for us to be admitting and keeping the patient with bronchiolitis for more than two weeks. Of course, I'm not prescribing for what the clinician should do, or we need to be monitoring them, looking whether there are signs. And also, we shouldn't forget doing the pulse oximeter, trying to monitor the saturation. Then some of the patients I've mentioned, they might progress to respiratory failure requiring assisted ventilation. And most cases of bronchiolitis resolve completely. The recurrence is common, but tends to be mild and should be assessed and treated similarly to the first episode. There seemed to be an increase in the incidence of asthma in some of the patients with bronchiolitis. As far as what is the causality is concerned, I look at the literature, I didn't get much. Of course, some of the colleagues in the group who are experts in the field might explain to me, well, what could be, might give me a better understanding. But some of these patients, but one of the things they felt that some of the patients who end up getting asthma will be those ones who present earlier with bronchiolitis, those who present with severe bronchiolitis. Of course, some of those patients with a family history of asthma, or the family history of asthma and atopy, might subsequently lead to asthma. The mortality is very low, 1 to 2%. But of course, as a doctors or advocates, we wouldn't love to get any patient dying from bronchiolitis. But most of those patients, luckily, we tend to pass on are those ones who have got pre-existing risk factors, especially the cardiac lesion, especially the immunodeficiency patient, and also some of those patients who, as I've mentioned, some of the patients are living with HIV can still have bronchiolitis. Some of the congenital structural abnormalities of the airways. Really, some of the patients, especially with adenovirus infection, they can also have a permanent damage, more called bronchiolitis obliterans. I think I might be missing some of these patients. I haven't seen some. Of course, I'm not a pulmonologist, but we know that some of the patients can lead to bronchiolitis obliterans. Yeah, okay. The prevention. How do we prevent bronchiolitis? As I've mentioned about how is it transmitted, the most important thing we have got about 3 modalities of prevention. There's environmental prevention. On the environmental prevention, we are talking about talking to the parents, especially the mothers, that One of the risk factors for bronchiolitis is smoking. Even the smoking during pregnancy, those patients tend to be more likely to get bronchiolitis. Therefore, we have to discourage the smoking in the case. And secondly, we have to encourage the mothers to breastfeed, because breastfeeding is also one of the important preventative measures. And another important thing is for the parents to encourage the parents as far as hand washing. Washing their hands, especially when they find that they've got babies at home. Then with that, there's one with respiratory problem. They should make sure that there's a good hand washing hygiene. Those are the most important things which will help us, especially also us as health workers. When these patients are admitted in the ward, we need to try to make sure that we isolate them as much as possible from other patients. Because if we don't isolate, as I've mentioned, that about 2 meters, if the patient is about 2 meters from the distance, they're more likely to catch the RSV. And also, when we're examining this patient, we need to make sure that we wash our hands from one patient to another. And also our stethoscope, we need to make sure that we cleanse our stethoscope with alcohol-containing fluid so that we're able to prevent the spreading the bronchitis to other children. As I've mentioned, sometimes they might end up doing the test so that we are cohorting them, but that is not really an indication for prevention. Then we have got now the immunotherapy now. On the immunotherapy, of course, we are a poor country, South Africa. Most of our people don't necessarily have medical aid. Most of our people not necessarily can afford. But in those ones with medical aid, there is a recommendation for using palivizumab. The palivizumab is an RSV-specific monoclonal. It more act on the fusion protein. The fusion protein of RSV, one which helps with the penetration. It binds to that. Therefore, it can be able to prevent bronchiolitis. It's usually given as a 5 injection before the season and also during the season for 4 months. The dose is about 15 milligrams per kilogram. It's usually initiated before the onset. The indication mostly will be the XPREM, the chronic lung disease, so very low birth weight, hemodynamically significant. Of course, from the primary, I'm not sure the experience of other area. Other medical aid is very difficult to motivate for palivizumab, but in others they do give them. Therefore, I'm not necessarily saying we need to be ignorant and not try to motivate for palivizumab for our patient, because it is very important. It has been found to reduce the infection of bronchiolitis significantly in those patients with risk factors. They are also user-friendly new monoclonal antibodies like nesivimab. And unfortunately, in South Africa, I'm not sure whether there's an area which has got it. We don't have. It's a single drug, and the single drug which reduces the infection about 78%. Is a very, but at the moment we don't have it. There's also others new in the pipeline. There's MK1654, but at the moment we don't have that one. Then also there's a importance of immunizing of the mothers during pregnancy. There are a vaccine on the pipeline to immunize the mother so that you can prevent the spread the disease during the first 6 months. Also, there are some trials which are looking at the vaccination of the baby, of the children themselves before 6 months. All those things are still there. I'm not sure whether there are some centers in South Africa which have started doing that, but I've just read in the literature that some of them are still on the trial. But there is hope, there is evidence that will help us, because mostly the RSV is severe in those ones less than 6 months. Those ones less than 6 months are those also more likely to die, especially the XPREM. I think the future is good as soon as we get that. The other important thing, some of this patient with acute bronchiolitis, because as I've mentioned that the RSV infection can have co-infection of other viruses. Therefore, immunization with influenza virus can help a lot in a case of those patients older than 6 months, and it may help also to prevent, if not necessarily severity of bronchiolitis. with these colleagues, I know I was rushing, and I also would like as a take home. This was my last slide as a take home, is that the bronchiolitis is there. Bronchiolitis is a pattern both on the morbidity and on the financial pattern. But the good thing is that bronchiolitis can be prevented. Part of prevention of the death from bronchiolitis will be as far as the identifying it clinical exam in the clinical picture and able to identify it. And secondly, to treat it properly. We know there is no rule for other treatment bronchiolitis that because they've also got their underlying side effects. We need to avoid that. And lastly, the importance of education of the parents, especially education of the parents as far as the symptomatology. Sometimes the parents tend to panic mainly because they assume that all the patient, if the child has got a respiratory tract infection, the child needs to be admitted, needs to be given antibiotics. Therefore, we need to be able to talk with our patients, to the mothers, to explain what is bronchiolitis, and also to be able to teach them about them being able to detect any features of severity so that they can be able to communicate and come to hospital. Therefore, in part of your teaching, you are also teaching the features of severity. And lastly, we shouldn't forget that there are preventative measures which we can do, especially preventative measures as far as make sure that ourselves, when we see this patient, we isolate them. Number two, we are able to make sure that we wash our hands, we clean the stethoscope, and for us to be able to prevent the emergence of antimicrobial resistance, let's try to avoid using unnecessarily antibiotic in this patient. Of course, as I mentioned, that you need to be able to look to examine, because if there is an indication, then don't be afraid to start up, but let's try to avoid unnecessarily antibiotic. In those ones we qualify for treatment, for example, the preterm babies, those ones with congenital heart lesion, we shouldn't be shy to apply to our medical aid. We shouldn't be shy to advocate to the medical aid so that they can be able to give synergies so that we are able to prevent this pattern of disease from affecting our children. With these colleagues, I would like to thank you. My references generally were the Clinical Update Journal, South African Medical Journal, by Ziad and the group, and also the Italian guidelines. I also did a bit of references in what you call it in some of those I've put there. With these colleagues, I would like to thank you, and I will like to, if there are any comments and the questions, I hope some of the pulmonologists in the group and some of the infectious specialists in the group will be able to assist me with some of the questions if I'm not able to answer them correctly. With this, I would like to thank you again. Thank you for being patient with me. I'm sorry for the hassle. I am in a Bundu area called Mafeking, and where there is a problem of Wi-Fi, and also myself, my age, sometimes I'm struggling to use this. With this, I would like to thank you, colleagues. Thank you very much.
Thank you very much, Dr. Titus. I think I'm laughing because when you say with your age, you're still very young, Dr. Titus. I think this was a brilliant presentation, very explicit, very eloquently delivered. I think very useful to everyone who's listening on the topic. As we in practice, not just the pediatricians, but I think general practitioners and other people, even our own children, babies and grandchildren. I think it's a very common condition that I think you've explained quite well. Yes, I think there are pediatricians in the group, in the audience. Doc, I think at one stage we had over 430 people logged in. I just want to say to members and the people in the audience that if you'd like to post a question, you can. There are two ways of doing it. A question or comment, any comment you'd like to make, you can post it in the chat group, or you can just raise your electronic hand and I'll recognize it, and you'll unmute, and then you'll say what you would like to say, whether you want to question or so. So people are allowed to speak. You just have to raise your hand and I'll notice it from my side. But thank you very much, Dr. Titus. I think there are one or two questions. Just maybe I see a lot of people posting their MP numbers, their HPCSA registration numbers. You don't need to do that, because when you register, you remember, when you registered to obtain the link for this webinar, you did give us your name, your email address, your cell phone number, and also your registration number with the council, whether it's a HPCSA, whether it's South African Nursing Council, whether it's a Pharmacy Council, whatever regulatory body that you are registered with. So we don't need that, but there are some messages which are saying, thank you very much for a brilliant presentation. It's a very good review, Dr. Titus. I think this is Dr. Kollega Hadebe. But let me start, Doc, with one question. There's a question here that says, let me go to the first one, just so that we take them the way. Is there any difference? This is, I think, from Dr. Sibuti Tsotetsi. He says, is there any difference in management of bronchiolitis, bronchitis, and bronchopneumonia? Any difference between treatment, management of bronchiolitis, bronchitis, and bronchopneumonia? Dr. Titus, you can go ahead and answer that.
Okay, no, thank you very much. Thank you for the brilliant question. Yeah, definitely there is a difference. As we have mentioned that the bronchiolitis is a viral infection, which basically causes inflammation of the bronchioles, and the management is supportive thereof. Then the pneumonia, definitely you are going to have cough, you have got tachypnea. The causality of bronchopneumonia can still, as I said, commonly, especially after the pneumo vaccine, the pneumo and the influenza vaccine, which has been very effective. Therefore, most of the commonest cause of bronchopneumonia will be basically the viral infection. Therefore, even bronchopneumonia can be supportive in the management, unless they've got toxic, there's immunodeficiency, immunocompromise, all the features which make you suspect bacterial infection, like also in your investigation, bloods, all that, then you'll start antibiotic. But in a bronchiolitis, there's no role for antibiotic. In a bronchitis, again, with bronchitis, again, it depends what is the causality of that bronchiolitis. Some of bronchiolitis are due to viral infection. Therefore, you won't necessarily have to give antibiotic. But the common thing in all of them, if they're in respiratory failure, you have to support oxygen, you have to support hydration, all that. But yes, there is a difference in the management of them. I'm not sure whether I've answered the question of the colleague.
Yeah, I think Dr. Tudis can, if is not answered, he can unmute himself and let us know. But I think there's another question. It says, can you make a diagnosis of asthma in a child who's less than 3 years? Dr. Titus?
No, thank you very much. There is the allergy and the pulmonology book, where I think there is a handbook of allergy. I've forgotten by allergologists. I've forgotten just the edition. In that it specifies, yes, you can still get asthma at the age of less than 3 years but there are some questions you need to look at which might make you suspect more possibility of asthma. It has got a good criteria where it will talk about when is this cough worse, how long this cough has been there, and also any atopy-related problems in this particular child, any response on the steroids or bronchodilators. Then when you look in all those features and others, I've been exhausted. I'm sure the pulmonologist will help me. They'll make you say, no, more likely here I'm having asthma. Then yes, you can still diagnose asthma in children less than 3 years.
Okay. The next question is can be controversial. It says, can you advise parents not to take their toddlers to school if their child is always getting sick from viruses from school? I think we've all heard of homeschooling and so on. Would you advise parents to take their children out of school? Or what would you advise? Dr. Titus?
Hi, Doc. I think we lost him again. I can't see him.
Oh, okay. Yeah, but I suppose anyone, maybe Dr. Titus, you can unmute yourself and give us your comment on that one. You must have been thinking something when you said that. Dr. Totezi? Everywhere is Dr. Titus back online?
He says he's going to rejoin, Doc.
All right. I think we'll wait for him before I go to the next question. But just to again advise attendees, I know some seasoned attenders here who are always part of our audience, and I would like to thank you very much for always logging in. I've seen a number of familiar names on this thing, and we've got a database of all of you. But I also know that some of you are logging in for the first time, and I would like to welcome you on behalf of Clinix. You let me know when Dr. Titus is logged in so that we can go to the next question. But
Yes, I'll let you know. But I'm afraid it might take long, like he did the first time when he tried to reconnect again.
All right. Okay, that's right. What I wanted to say to the new ones is I think I must have mentioned it briefly, that when you log in, you give us as much detail as possible when you register. And that's the whole purpose of asking for a short registration. It takes about 2 minutes to do your email address, your registration number. It's so that we can email the CPD points to you.
So I'm back now.
Okay, thank you. Points come automatically from HPCSA, so it'll only be a Clinix email, so that you don't ignore it. It'll be from the HPCSA, and it'll tell you within a week or so. We used to give certificates as well from Clinix, but there's no need for the certificates anymore because you get the CPD certificates, but instead you get the points directly. They get credited into your, can I say, your account with HPCSA in your HPCSA. All right, thank you very much, Dr. Titus. I think the next question, if I may go to the next one, I think it's from Dr. Nginza. Dr. Nginza says, my question is how to go about differentiating from acute bronchiolitis and acute bronchitis. I think we've heard that because they are similar in clinical picture. I suppose the first one was about management of bronchiolitis and bronchitis, but this one is about differentiating when you've got a child in front of you and you'd like to make sure whether it's bronchiolitis or acute bronchitis. You touched a bit in your presentation, but maybe you can do it. You can answer the question again, Doc.
No, thank you very much. No, to be honest, with the acute bronchiolitis, we said there's always a prodromal signs where this patient will be presented with a upper respiratory tract infection preceding the bronchiolitis. Then with the acute bronchitis, I'm not an expert in the field, but it can be due to viral. It can also due to be bacterial, but necessarily they don't present with the features of hyperinflation compared to acute bronchiolitis. But I think one of the pulmonologists can help me, but I'm one of those people who avoid diagnosing acute bronchitis unless I'm really convinced that I might be having acute bronchitis. But honestly, I'm not the clinical picture. I would assume mostly with bronchiolitis hyperinflated. Then the bronchitis I used to enjoy in adults as a chronic bronchitis and acute bronchitis, in children, we still can have it. But as far as how to differentiate, I'm not really sure.
Okay, thank you very much, Doc. I think the next one is from Dr. Philip Ramela. He says, well, you just said that you're not sure. He starts his question
bronchitis.
By saying, he also starts his question by saying, I'm not sure about what is the role of steroids, and I had a little bit about it, he also heard a little bit about bronchodilators when you spoke. So he just wants you to go back to the use of steroids, number one, and of bronchodilators.
Yeah, no, thank you very much, Doc. I mentioned, colleagues, that there is no role for bronchodilators as far as the acute bronchiolitis is concerned, especially if your history taking is good. You'll realize that I'm dealing with the acute bronchiolitis. Of course, there were previously where there would be Lisa saying you can do a trial of bronchodilators. In those ones who respond on bronchodilators, would assume that there's an underlying reactive airway disease. That is, there could be underlying possibility of asthma, therefore they will respond. But all the guidelines don't necessarily propose the trial of bronchodilators, including the adrenaline. There were also studies some time back who say adrenaline seem to be doing better. Remember, with the bronchiolitis, you've got an inflammation. You don't have a bronchospasm there. That inflammation is more of a viral, which usually will recover over the course of the time. Also, steroids themselves, there is no role for steroids as far as acute bronchiolitis. But of course, as I've mentioned, in the case of severe bronchiolitis, which end up needing to go to ICU, some of the intensivists have used the adrenaline together with corticosteroids, which seem to be working. But generally, in a bronchiolitis, there is no role for steroids. Also, there's no role for leukotriene antagonist, that is the metulocast, the singuli, all that, as far as bronchiolitis is concerned.
Okay, great. Yeah, I don't see any other questions. There's a question from, I think, Dr. Itumeleng Motloung. She says, it's in the case that you alluded to, was the cerebral palsy caused by the infection or by hypoxia? As you mentioned, a delay in the transition or maybe transporting of child from to ICU, there was a delay. So she's asking whether the cerebral palsy could be attributed to the bronchiolitis itself or from hypoxia? That's the question.
No, thank you very much. We thought it's alluded to respiratory failure, that is hypoxia per se. Though when we were reviewing, because it was a very delicate case, when we were reviewing, trying to look and say one also, because the child was basically encephalopathic, I must say, then when we were looking and say what could be the causality of encephalopathic in a bronchiolitis, the first thing was the fact that the child was hypoxic. We delayed to intubate, we struggled. Secondly, yes, infection, not necessarily as a RSV. There are some studies show that there could be co-infection with Bordetella pertussis, which can subsequently give encephalopathy, but bronchiolitis is several RSV won't necessarily give you encephalopathy. And lastly, we also look and say, how was the sodium? Because now if we had a bronchiolitis, you can also have a syndrome of inapproved hyponatremia to see whether could this hyponatremia have caused encephalopathy. You know, therefore, we thought more likely to be related to hypoxia.
Okay. Yeah, a related comment or question is from Dr. Ramofi, Dr. Edibone Ramofi, and she says, although hypertonic saline and bronchodilators are not recommended, as you said, so we can't give it at all. We can't give it as a trial to see if the child will respond. I mean, there's a question. Can they be given as a trial to see whether the child will respond or not? So it will be will it just strictly subquative and nothing else? That's the question. What would you say to that, Dr. Titus?
No, good question, Doc. Of course, there is a practical what we are used to, and there's also evidence, guidelines as evidence. You know, then when I was reading around the guidelines, all the guidelines are not necessarily talking about the trial per se, but they are looking and saying what can cause the deterioration will be more like to do with the severity of respiratory failure. Therefore, you monitor your oxygen. If on nasal prongs, for example, the patient is not improving, you might have to elevate to high flow nasal cannula. If on nasal cannula there's no improvement, you might elevate to the CPAP. Subsequent in severity, you might elevate to ventilation. Yes, I must be honest, at the practical level, when you are what you call it, you are in the ward, you have done all the trials giving, but I'm not sure whether there's an evidence in our trial which say that because I've given this patient hypotonic or bronchodilators, therefore this patient recovers earlier compared to another patient who was not given the hypertonic or was not given the bronchodilator versus to the one who was given oxygen, high frequency, high flow nasal cannula. In a nutshell, I'm saying, yes, I know we do those things, but do we have evidence? Because I was looking at recent literature saying there is no evidence. Even as I said, quoted the clinical update of Prof Ziad and the others, there was all the more infection guides and also pulmonologists. They are not necessary, but of course there's a practicality. If practically Dr. Ramofi has an experience that some of them, they seem to be responding well with the trial, then and there's evidence. I think that is something which could be done.
Okay, I think this is the last one. It's also from Dr. Tsotesi, and the question is, can we give empiric Tamiflu if we don't have resources to do a swab? Can we give Tamiflu empirically?
No, thank you very much. You know, I must also confess, I'm working in a rural area in a Mafeking Provincial Hospital, and I haven't used Tamiflu in the patient with bronchiolitis. There's no Tamiflu. Also at the private level, at the private Victoria, honestly, I haven't used Tamiflu. Maybe the pulmonologist might comment as far as the evidence saying giving Tamiflu, it helps with the recovery. It reduces the length of stay it reduces as far. Then at the moment, I'm not sure whether would it really reduce the length of stay, also will reduce the severity of the disease. Of course, as I did that I'm not a pulmonologist, but I haven't seen the evidence talking about prophylactic Tamiflu.
All right, thanks. I don't see any hands from anyone. People are afraid to talk, tired. It's been a long day, I suppose. But I think we've exhausted all the questions. But if anyone has any questions or comments to make to Dr. Titus, they can email them to us. I think, and then we can pass them on to Dr. Titus. But at this stage, maybe find out in the meeting. Can you check whether Professor Velapi managed to log in?
Yes, I've joined, Chair.
Oh yes, thank you very much, Professor Velapi. Thank you very much. I think we've got two members of the Clinix. I think I've introduced you before, even last week. We've got two members of Clinix Clinical Risk Advisory Committee that always makes sure that all of us within Clinix, clinicians and all healthcare professionals within Clinix Health Group, do the right thing, as far as clinical governance is concerned. And Professor Velapi is head of pediatrics and child health in this medical school and also Krisani Bara Academic Hospital, but he also is one of the team. Another professor we have with us today who is part of the team that assists clinical governance is Professor Sipati Magunyani, who is also in the audience today, and she's head of ophthalmology at Steve Biko Academic Hospital, the University of Pretoria. But Professor Velapi is also a pediatrician, and I'm sure he's been listening. Prof. Velapi, would you like to make your comments and maybe your vote of thanks before we close the session? You can go unmute yourself and go ahead, Prof.
Good evening, colleagues. Can you hear me, Chair?
Yes, I muted myself. Yes, we can hear you clearly, Prof. You can go ahead.
Okay, no, thank you very much, Dr. Titus.
You can also unmute. You can also open your camera if you want to. It's optional.
The boss has not allowed me. I tried to open, but the computer, I'm not sure it's from your side or it's my computer.
No, that's
You can try again, Prof.
Yeah, if Dr. Titus is old, me, I'm ancient. Okay. You can hear me.
Yes, Prof, we can hear you.
Okay, thanks.
We can hear you, Prof. Yeah, I see you just closed your camera, but we can hear you very clearly.
Okay, thanks. Thank you very much, Dr. Titus, for this a great overview of a review of the topic. Sorry, you've done an excellent job, and you covered all the areas. I've got nothing much to add, other than taking this time and advertise. You mentioned Professor Dengo, who has written some of the guidelines on the bronchiolitis. Professor Dengo has also written a chapter in our protocol book. We've got a protocol book at Bara Pediatrics, which has been released this year, which covers different topics in pediatrics, focusing mainly on emergencies. And one of those topics is bronchiolitis and asthma. So people who want to look at that can have a look at that. But looking at my training as a neonatologist, I just want to emphasize what you mentioned about the prevention. That it has been shown in terms of randomized clinical trials that giving a vaccine to mothers during pregnancy reduces the risk of these babies getting bronchiolitis. So if you look at the vaccine effectiveness given to the mothers, that effectiveness is about 80% looking at the first 90 days and about 70% by 180 days, which is 6 months, where most of the time bronchiolitis manifests. So it's commonly within the first 2 years, but I think it's much more common within the first year. So I think that needs to be highlighted. And I think, again, you have covered the important thing that we should not rush giving these babies antibiotics, giving these babies steroids and all that, and because this is a viral, as you say, is self-limiting 2 to 4 days. But of course, one must look at the severity. You can use the TAL score, which will say if you've got a score of 11 to 12, that's quite severe. And in that case, you might have then to do some investigation and some tests because they might need further intervention. So I think overall, perfect, excellent talk, Dr. Titus. I think as Dr. Kinosha has mentioned, that as part of Clinix, the aim is to improve the quality of care that is provided all over the country. But as part of that, we need to get updates from people like you who are working in the field. We've got both the experience, but also can review the literature as you have done. Thank you very much. Let me also take this opportunity to thank everyone who has attended. I think we all come from different backgrounds in terms of the work that we do, starting from the nurses all the way to the subspecialists in terms of pulmonology. We thank you very much. You're welcome to continue joining these webinars that happen on a regular basis. Thank you again, both to, and especially we also encourage the participation through asking questions and don't be shy to raise your hands. We need to be academic about some of these topics and talk about evidence and ask the questions that are relevant, which will talk to what we do on a daily basis, being informed by the literature. And of course, the expertise are also needed because when you've got the evidence plus your experience in the field that you have shown that you've been working with these babies for years, it does make a big difference. Thank you very much, Dr. Titus. And thanks to everyone, and thanks to Clinix for this opportunity.
Thank you very much, Professor. I need to also our technical assistant in the background is as a viewer, Maketuka, who's been doing the technical work in the background. But thank you very much. We will send out the notifications for next week's webinar in the email addresses that you've sent to us. Thank you very much, everyone. Good evening.